Good morning, everyone. I'm excited to welcome you to today's presentation. We'll be exploring the important topic of upper GI bleeding. Our focus will be on understanding key landmarks, specifically the ligament of Treitz, which helps us differentiate between upper and lower gastrointestinal bleeding. Over the next few slides, we'll cover the anatomy, clinical significance, and diagnostic approaches related to this. Let's get started. Let's take a closer look at the causes of upper GI bleeding, specifically hematemesis. The most common culprit here is peptic ulcer disease. This can be due to either a duodenal ulcer or a gastric ulcer. When we talk about duodenal ulcers, the bleeding usually originates from the gastroduodenal artery. On the other hand, gastric ulcers tend to bleed from the left gastric artery, with the most common site being the lesser curvature of the stomach. Now, regardless of whether it's a duodenal or gastric ulcer, significant bleeding can cause a sudden drop in blood pressure, which we often refer to as crashing blood pressure. This is a critical point because it underscores the urgency of prompt management. Speaking of management, the first step is establishing gray IV cannulation to secure venous access quickly. Then, administering a fluid bolus helps stabilize the patient's blood pressure. In severe cases, we follow a massive transfusion protocol to replace lost blood efficiently. Once we achieve hemodynamic stability, the next step is usually upper GI endoscopy. This allows us to visualize the source of bleeding directly and often perform cautery to control it. Overall, understanding these causes and the immediate management steps is essential to improving patient outcomes in upper GI bleeding cases. Let's talk about drug-induced gastritis first. Certain medications, like COX-1 inhibitors such as indomethacin and ketorolac, can lead to erosive gastritis. These drugs impair the protective lining of the stomach, making it more prone to damage and erosion. In contrast, H. pylori infection typically causes non-erosive gastritis. This means the inflammation is present, but it doesn't necessarily lead to visible erosions or ulcers in the stomach lining. Moving on to portal hypertension, this condition is characterized by an increased pressure within the portal venous system. It often presents with hematemesis, which is vomiting blood, especially when accompanied by splenomegaly or an enlarged spleen. A key point here is that portal hypertension is defined as a hepatic venous pressure gradient more than 5 millimeters of mercury. Once this pressure exceeds 12 mmHg, the risk of rupture of esophageal varices significantly increases, leading to potentially life-threatening bleeding. Now, where does this bleeding come from? The source is usually the coronary veins and esophageal collaterals, which are enlarged and tortuous vessels that develop in response to increased pressure. These collaterals connect with gastric veins, creating pathways that can rupture under high pressure, resulting in bleeding episodes. Understanding these mechanisms is crucial because they help us recognize the severity of portal hypertension and its complications, which ties back to our overall theme of gastrointestinal pathology and management. Let's now look at the leading causes of portal hypertension. The most common one is alcoholic cirrhosis, which results from long-term alcohol abuse leading to liver scarring and increased pressure in the portal vein. Beyond alcohol, liver damage can occur without viral markers, and when it's not related to alcohol or metabolic issues, we refer to it as cryptogenic cirrhosis or non-cirrhotic portal fibrosis, often abbreviated as NCPF. These are important to recognize because their management differs slightly. In pediatric patients presenting with splenomegaly, we should consider extrahepatic portal vein obstruction, or EHPVO. This condition involves blockage outside the liver, leading to increased pressure and enlargement of the spleen. Now, regarding variceal management, if a patient has non-bleeding esophageal varices, propranolol is typically used. It's a beta blocker that reduces portal pressure and helps prevent bleeding episodes. Speaking of propranolol, its uses extend beyond variceal prophylaxis. It's also effective in managing migraine prophylaxis and is used in hypertrophic cardiomyopathy, or HCM, to control symptoms. When a patient presents with bleeding esophageal varices, The immediate treatment involves infusion of medications like octreotide or terlipressin to control bleeding. The definitive treatment of choice is upper GI endoscopy combined with sclerotherapy, where we effectively obliterate the varices. So, understanding these key points helps us approach portal hypertension comprehensively, from its causes to its management strategies. Let's discuss Mallory-Weiss syndrome, which involves a submucosal tear in the esophagus. This condition is often linked to episodes of forceful retching or vomiting. Now, certain groups are more prone to this, such as individuals who engage in binge, drinking alcohol, or pregnant women suffering from hyperemesis gravidarum. These scenarios are particularly noteworthy because the repeated retching can cause tears at the gastroesophageal junction. In terms of presentation, patients typically come in with retching episodes followed by hematemesis, which is vomiting blood. Sometimes, this can lead to vasovagal syncope, resulting in fainting. On examination, you might notice an increased heart rate or tachycardia and blood pressure that can be around 100/70 millimeters of mercury. Most cases tend to be self-limiting, meaning they resolve on their own without extensive intervention. However, if bleeding reoccurs or is severe, we consider further diagnostic and therapeutic steps. These include performing an upper GI endoscopy to locate the bleeding source and administering treatments like adrenaline injections, cautery, or endoscopic clipping to control the bleeding. The bleeding usually originates from the left gastric artery, which supplies the stomach and lower esophagus. Recognizing these key points helps us connect the clinical presentation with the underlying pathology and guides us on how to manage these cases effectively.